Assalamu alaikum. This talk was supposed to be given by South, but unfortunately he could not make it. So now you guys were stuck with me. So osteotomies were once considered luxuries and were performed only in select specialized centers around the world. But now with the number of fellowship trained spinal surgeons increasing and the centers giving these training increasing, these surgeries performed in most of the tertiary care hospitals routinely. The considerations while planning a patient for these surgeries are the type of deformity, rigidity of the deformity, location of the deformity, presence of spinal compression, previous surgical procedures, angular versus a smooth curve, patient medical status, and surgeon's experience. The patient factors become very important because these are long and extensive surgeries. So age, prior surgery, comorbidities, diabetes, hypertension, cardiac disease, and some modifiable risk factors like obesity, smoking, and osteoporosis should be corrected as much as possible before you go in for these surgeries. Uh, like obesity, increasing size makes surgical exposure more difficult. There's more blood loss, risk of PE, and poor mobilization also poses risk. You need to have a threshold for the BMI, and if it can be delayed, ask the patient to decrease their weight before they come to you. They should meet you halfway. They have to put an effort, and you have to put an effort. Stopping smoking helps. Even reducing the number of smokes helps in reducing the morbidities. Osteoporosis is a big problem in these surgeries. Bisphosphonate, calcitonin, estrogen replacements can be done. DEXA scans should be done preoperatively in all these patients. And if there's a T-score of -3, then try to start parathyroid analogs. They are the only medication that increase bone formation, but obviously they have cost issues attached with them, especially here in Pakistan. Now, in surgeon factors, experience is very important. You need to have experience before you go in for these surgeries. Do a lot of cadaveric courses and then do a couple of fellowships with some trained surgeons, and then only you should start with these surgeries. Then again, the location, the level at which you want to do the vertebrectomy is very important. You should pay some time and attention and measure all the different angles and things that Dr. Salman was telling you, and I think owner will give us more detail about it. You should have a thorough workup before you select your levels and the location of your vertebrectomies. You should always have help available because these procedures can have different problems, and you should have all the senior help available if you're going for these surgeries in your initial stages. And also some ancillary surgery like vascular surgery, general surgery, and other things should be at your backup in case something wrong happens. In your early practice, you don't want complications, and you don't want to do these cases very early in your practice. And also keep in mind what kind of setting you're working in, what kind of support you have, and what the hospital provide. If you have proper bed, equipment, reps, implants, also unanticipated implants that are not regularly available in your usual sets, they should be available to you because you never know what kind of emergency you can run into. You should have ICUs, resident fellows, neurology, and other physiotherapy teams available for you. In 2010, Lenki published this flowchart to help you in the decision making of what kind of vertebrectomy should be performed. But again, it's not absolute. So to achieve an correction, you need a thorough surgical planning. You should determine the amount of correction needed. Flexibility of the curve should be seen. And then prone, spine film, CT, X-ray, MRI. I think you'll have a detailed discussion with owner. The procedures that can be done, posteriorly we can do facetectomies, osteotomies, vertebral column resections. Anteriorly we can do discectomies and interbody fusions and put implants that increase the lordosis and help us doing less posteriorly. Laterally we can do discectomy, ALLs, releases. So how to determine if you want to go anterior or posterior? If it's flexible, usually posterior only works. If it's fused, usually osteotomies are required. If it's stiff with good lumbar lordosis, 20 to 30 degree, posterior only can work. If it's poor lumbar lordosis, anterior and posterior will be required, especially if it have a very high pelvic tilt. And laterally, we can use it for adjacent level disease with prior fusion and flat back deformities because it decreases the morbidity rather than going anterior posterior. So the equipment is also required. These procedures are usually equipment extensive, especially in these days where you need good spinal navigation or adjunct technology aid. They help in the safe delivery of hardware into the patient. And other ancillary equipment that you might need is a good 3D C-arm, fluoroscopy, CT imaging guidance, robotic technology, dynamic surgical guidance. Combination of these above technologies are available in different combinations. These need is guided by the surgeon's comfort and preference, as well as the realities of cost and availability. New and improved technologies are coming, and the robotic surgeries are also decreasing the burden on the surgeon. Neuromonitoring for maximal expiratory pressure, somatosensory evoke potential, and spontaneous and triggered EMGs is extremely beneficial. So the kind of speciality that you need, ideally availability of 1 or 2 specialized spinal surgeons during osteotomy procedure is preferred. The lead surgeon should be a spinal surgeon, well trained and comfortable with complex deformity management. He should have a dedicated anesthesia team and neuromonitoring team, which include a monitoring technician and a neurologist. Proper liaison with medicine, critical care is also important. For pediatric cases, again, Dr. Hassan just told us, the children are not small adults. You need to have a multidisciplinary team, which includes spine surgeons, primary pediatrician, dietary specialists, physical therapists, cardiologists, pulmonologists, gastroenterologists, child life specialists, and social workers. So proper counseling and proper discussion pre-op is very important. You should have realistic goals, and the patients and the family should have realistic expectations. If they don't match, I think you should not go for these surgeries. So the basic osteotomies that we do is Smith-Peterson osteotomy, Ponti osteotomy, pedicle subtraction osteotomy, and vertebral column resections. So this diagram shows the different bone resections that we do in different osteotomies, starting from Ponti to multi-level vertebrectomies. Smith-Peterson described his osteotomy in 1945. It was described for mostly posterior releases, and it was originally described for use in the rigid spines, ankylosing lumbar spines. It relies mostly on mobile disc space. 1 millimeter is achieved by resecting 1 millimeter of the facets. The total resection gives you about 10 degrees of correction. You have to remove supraspinous, intraspinous ligamentum flavum with facetectomy to produce posterior release. Ensure exiting nerve roots are decompressed adequately. Posterior compression of osteotomy brings about kyphosis correction, and SPUs are generally labeled as Schwab 1. So here you can see that the posterior elements are resected and the defect is closed, causing lordosis and compression posteriorly. In Ponti, described the similar bone resections through an open disc space. It was described initially for Scheuermann's disease. Entire facets are resected. The difference between SPO is that SPO was described in an already fused spines like lumbar scoliosis, and POs is more aggressive and mostly done in dorsal spine. Usually they are used interchangeably, but this is the most important difference I could find. They are usually classified as Schwab 2. The pedicle subtraction osteotomies were first described by Thompson in 1985. It can be used to correct sagittal and coronal planes. Complete anterior release is avoided. Frequently used in revision surgery and flat back. Posterior only approach and a 3-column resection is done. It needs a larger exposure, and temporary rods are applied because it's a destabilizing surgery. And SRS classification 3, if you extend it, it falls into 4. So they're typically performed for large correction, and they shorten the chorda extent of lengthening it. So it's also safer. Less often in cervical and thoracic spine. Bony resection determines the final alignment that you can achieve. 30 degrees of correction can be achieved at best, and it should be done at the sharp deformity curves, at the apex usually. So here you can see that you remove the spinous processes, the pedicles, and you wedge the body. Setup usually requires neuromonitoring, measure pre-op, all the different angles. You should know the degree of alignment that you are going for, and include all the pelvic parameters and plan thoroughly. Expect blood loss, cell savers, anticoagulants, tranexaminic acid or amica can be used. Blood products should be saved accordingly. Exposure should be careful not to do excessive bleeding during exposure, because you will need a lot of blood when you're doing the osteotomy. First, screws are placed and rod is placed on one side because I told you it was a destabilizing surgery. If excessive blood loss more than 2 liters before you start your osteotomy, I think it's better to stage the procedure. If you have signal changes in your neuromonitoring, it's better to remove the instrumentation and stage it. So if you want to do an L3, decompress that level. Often scar tissue is there, remove it completely, remove the lamina above for minimum and adequate exposure of the nerves, identify the exiting nerves on the level above as well, dissect pedicle to pedicle. So you will go from the first circle to the second circle, remove all the bony parts, remove the transverse process, remove interior body, then lateral body, dissect laterally using cob and place a malleable retractor. Medial pedicle and posterior body should be done last, and must remove all the posterior body elements which can cause neurological injuries if you have bony spur left there. Overcontour the rod and multiple rod techniques can be used. You can use 4 rods, cantilever bending, or bed reduction to achieve your reduction. Dura will buckle when you reduce it. You have to keep in mind that the nerves are free, and you should feel under the dura that there's no anterior compression or bony spurs, and check for signals on your monitoring. So this cartoon shows the amount of bony resections you have to do in Untitled and AP view. Vertebral column resections, these are the most extensive ones. They were first described in 1922 by McLean, who performed an apical resection from the posterior only approach with postoperative casting for treatment for severe scoliosis. In 83, Locke presented 8 cases of vertebrectomy in patients with primary spinal deformity of more than 90 degrees. In 2002, Suck developed a posterior only approach for VCR. It is useful when the cord is draped over your deformity. Complete anterior and posterior release is possible. Temporary rods need to be placed during the surgery. Avoid lengthening of the spinal cord because it does not tolerate stretch. The SRS Schwab complication is 5, but if you go into the adjacent disc space, it becomes Schwab 6. It is best suited for more complex deformities, and the deformities include rigid multiplanar deformity, fixed coronal imbalance, hemivertebral excisions, and sharp angular deformities. A correction of 35 to 60 degrees can be achieved through these resections. So this is the main difference. You start with the facets, and then you go into the body, or you can complete the whole body. The aggressiveness is increasing progressively. Again, a word of caution, the 3-column osteotomy should be preserved for the patients with significant rigid deformity. Consider patient's functional status, bone quality, medical comorbidities, and other overall quality of life goals before you go for these extensive surgeries. So for VCR, pedicle through fixation, at least 4 levels above and 4 levels below should be done. Separate paravertebral muscles and lateral vertebral body after resection of the transverse processes. Protect segmental vessel which goes along the lateral aspect of the body. Posterior elements are removed completely. In dorsal spine, the exiting nerve root should be exposed, and in thoracic level may be tied off. They can also use for mild traction. Resection of the ribs may be required. Up to 4 centimeters can be taken. Pedicles are resected either with the bone, scalpel osteotomy, or a high-speed eggshell drilling. Piecemeal removal of the bone, leaving a very thin rim of the cortical bone interiorly. Temporary rods are placed and pedicles are resected. The lateral portion of the pedicles and vertebral body, as well as a thin rim of the posterior vertebral body, are left for the last. Posterior wall of the vertebral body can be taken down with the down pushing curette or deformity specific instruments. Care should be taken not to violate the sac. Osteotomy is then closed with posterior compression. Final rod placement is then obtained with 4-rod construct of PCR. These extensive procedures have complications and usually range from 10 to 96%. The Skona study showed weakness in 22% of the patient, which improved at 6 months in 20% of the patients. The International Spine Study Group showed 78% overall complication rate, with 61% of the patient having significant complication. And Lenke showed in children about 40% overall complication rate, with 11% neurological complications. The common complications include iatrogenic injury to the spinal cord, nerves, durotomy, infection, and pseudomeningeal seal, and injury to the neighboring structures such as pneumothorax, pleural effusion, large vessel injury, abdominal injury, deep vessel thrombosis, myocardial infarction, and pneumonia. And you should have backup for all of these. Following the surgery, the patient must be monitored for instrumentation failure, as well as development of proximal junctional kyphosis and proximal junctional failure. Normal tips and tricks are: you should have neuromonitoring if there are very steep curves. Be careful with shortening the spinal column and use expandable cages to give you more control. Translation causes paralysis. Avoid it at all costs. Keep anterior column intact till the last. Do not remove ALL and eggshell anterior cortex like a PSO. Nerve root in the dorsal spine can be tied and used for gentle retraction when you're working anteriorly. Use rib head to define your disc space and work from disc space to disc space to ensure that you're doing complete excisions. Prep for wide and possible chest tube, because if you have an inadvertent entry into the pleura, then you need a chest tube, and do counsel the patient beforehand about all these possible complications that you may get into. Pre-operative planning is the key. You should get proper measurements before you go in, so you should know exactly what degree of correction you actually need. So the trick is measure twice and cut once. So these are the classification systems, but I think we have a separate presentation on this. So thank you.